The European Society of Cardiology asked for guidelines on pacemaker implantation because they and the committee believed that certain aspects of pacing could be improved in Europe. We knew that pacing varied in standard across Europe and that there were many patients still receiving single-chamber ventricular pacemakers for sinus node disease. And we felt that this was inappropriate and that with good guidelines we could have an impact. For sinus node disease patients, pacing should be in the atrium unless there is no AV conduction. In the latter part of the 90s and early 2000s, we recognized that pacing in the ventricle was potentially harmful to those who didn't need it. In sinus node disease, many patients have normal ventricles. Adverse effects can occur, and they are primarily heart failure or atrial fibrillation. There's abundant evidence that just programming a long atrioventricular delay in a dual-chamber pacemaker for sinus node disease is inadequate. So this choice is today considered inappropriate. In order to provide atrial pacing for all of the time when conduction to the ventricles is occurring spontaneously, the ESC group recommended an algorithm which would have atrial-based pacing, but this would not be atrial-paced under certain criteria. If there were two consecutive non-conducted atrial events, this was diagnosed as third-degree atrioventricular block. Dual-chamber pacing began. If there were 3 out of 12 non-conducted atrial events, this would constitute second-degree atrioventricular block, and the device would switch to dual-chamber pacing. And thirdly, in the context of prolonged AV delay, prolonged PR interval as it would occur spontaneously, then if there were 7 long PR intervals, dual-chamber pacing would begin. The thrust of the ESC guidelines for sinus node disease patients is atrial-based pacing to be used continuously, but combined with an algorithm that will provide ventricular pacing when necessary, that is, when some delay or block in conduction occurs to the ventricles.